Afternoon, everybody, and thank you to the EF for an exciting meeting so far, and thank you all for hanging in there with me. My only disclosure is that myself and the others who contributed to this are paid employees of Neurelis. Next slide, please. So Diazepam nasal spray, or Valtoco, was FDA approved in January of 2020 for the acute intermittent treatment of seizure clusters in patients with epilepsy ages 6 years and above. Today, I'm going to be telling you about some of the interesting results we've generated from our phase 3 open label repeat dose safety study in patients ages 6 to 65 years over the course of 12 months. 175 patients enrolled in this study, and 163 of them received at least one dose of diazepam nasal spray and were included in the analysis. In total, 4,390 doses of diazepam nasal spray were administered to treat 3,853 seizure clusters, a really large seizure cluster cohort indeed. Per the protocol, patients could also receive a second dose of diazepam nasal spray for the treatment of their seizure clusters if needed. And this occurred in 485 events, or 12.6% of the seizure clusters. Overall, the safety profile was consistent with that of rectal diazepam, our reference label drug. Next slide, please. Today, what we want to talk about is something a little bit different. So our past analyses have really focused on kind of the overall usage and have shown that there was a mean of 2.3 doses per month per all patients throughout the whole course of the study. But we realized that this is really kind of losing some of the interesting context of seizure clusters, and we really wanted to understand the pattern of usage over the course of the study. So to do that, we started looking at the timing or interval between the doses of diazepam nasal spray. This is a post hoc analysis, and I'm excited to share with you these preliminary results where we looked at the time interval between these seizure clusters using 90-day periods. If you look at the subject disposition on the right, you'll see that we started with the 163 patients in the safety population. There were 12 patients who only received one dose of diazepam nasal spray during the course of the study. Thus, they did not have any of these SEIVALs, or seizure cluster intervals, and were eliminated from this analysis. That left us with 151 patients who had at least one of these SEIVALs. But since what I told you is we were most interested in the pattern of this over time, we developed an analysis where we looked at the SEIVALs over 90-day periods. And there were 31 patients who did not have data in both the first 90-day period as well as a later period for that comparison. So those 31 patients were excluded. That left us with 120 patients who had this SEIVAL data in both the first 90-day period as well as a later period. So we could look at that pattern over time. I'll show you that data on the next slide. But what you will see is that there was a decline in the number of subjects over those 4 periods, or about 1 year. And we thought that this could potentially be due to survival bias. So we also, to account for this, looked at a consistent cohort of patients who had data in every period between periods 1 and 4. We also did this analysis in a consistent cohort of patients who had data in every period between periods 1 through 5 and periods 1 through 6. For the purposes of this talk, we'll focus on those 76 patients who had data in periods 1 through 4. As I mentioned before, some patients also did use a second dose within 24 hours. And in order to really look at that interval between seizure clusters, we also went back and eliminated retreatment of the same seizure cluster within 24 hours. Next slide, please. On the left-hand side, what you can see is the data from all patients who had SEIVAL data in both the first 90-day period as well as a later period. So that was 120 subjects to start with. And along the bottom, you can see the period as well as the days that that corresponds to. And on the y-axis, what you see is the mean SEIVAL. Again, that's the time between treated seizure clusters. And what you see is this interesting observation where in period 1, those 120 patients had a mean time between seizure clusters that were treated of about 15 days. And this significantly increased out to period 4 to 35.8. Again, I call your attention to the fact that there was a decrease in the number of patients. And so to address this, we did that consistent cohort analysis of the 76 patients who had data in every period between periods 1 through 4. That data is in the right panel. And if we start with the navy blue bars, those are those 76 patients, and we see that their mean SEIVAL in that first period, again, the time between treated seizure clusters, was 12.2 days, and this increased significantly to 25.7 days in period 4. If we look in the light blue bars, this is now those same 76 patients where we've eliminated retreatment of the same seizure cluster. And what we see is that their mean SEIVAL increases from 13.9 in period 1 out to 26.8 in period 4. Now, this, regardless of which cohort or which analysis, you see the same consistent pattern and significant increase in the time between treated seizure clusters over about a year's duration. Next slide, please. So in a drug-resistant population, one of the most common things that may happen over a year's time is that they may have changes to concomitant medications. So we thought about this, and this was one of the first sub-analyses we wanted to evaluate. And here what you see is that, as expected, the majority of the patients within that consistent cohort did have a change in concomitant medications. Those are the 56 subjects in the navy blue. And what you can see is that there's still the same pattern of the significant increase from period 1 of mean SEIVAL of 13.9 up to 25.8 in period 4. This is the same pattern that holds for those 20 subjects who did not have a concomitant medication change over this same time frame. We did a number of other sub-analyses, including looking at the median SEIVALs instead of the means, looking at the different age groups, since we had both pediatric and adult patients, as well as the consistent cohorts out to periods 5 and period 6. And the pattern was always very consistent. Next slide. In addition to looking at the seizure diary to be able to give that SEIVAL data, we also started thinking about the seizure diary in a slightly different way as well. And here what you see on the left-hand panel is we took those seizure clusters from those patients in the consistent cohort, so those 76 patients, and we binned their data as to whether the dose of diazepam nasal spray was given within the first 5 minutes, or if it was given between 5 to 15 minutes. And what you can see is that if the dose was administered within 5 minutes, the time from dose to seizure cessation was a median of 2 minutes, and the total seizure duration had a median of 4 minutes. If there was a delay in that treatment and the dose was not administered until between 5 to 15 minutes, we now see that the time from dose to seizure cessation is 9 minutes and the total seizure duration is 16 minutes. We think this data is really telling us that we do not need to wait for that prolonged seizure mark of 5 minutes in order to intervene once a seizure cluster is recognized. Along with that, we've also started looking at our second dose utilization in the same consistent cohort. And we've found that if the dose is administered within 5 minutes, that there's a lower second dose utilization of 6.4% compared to 10.5% in those where the dose is administered between 5 to 15 minutes. Next slide. So we think that these are really interesting results that we cannot fully explain from this post hoc analysis, but what it really has done is sparked a number of hypotheses, and these include but aren't limited to a potential biological change to the actual natural history of seizure clusters when appropriate intermittent rescue therapy is delivered, or perhaps a behavioral change based on the recognition and dosing of these intermittent rescue therapies. Or perhaps this represents regression to the mean. But I think overall, we're excited about the discussion that this generates, and we are working through next steps and put it out there that maybe SEIVAL could be a prospective outcome for future trials. Next slide. So in conclusion, we think that these novel results may reflect a previously unrecognized effect of diazepam nasal spray rescue therapy. And regardless of the cause, these increases in SEIVAL that were significant and hopefully clinically significant show a reduction in the use of diazepam nasal spray over time. This confirms our prior findings that tolerance did not develop in this study cohort and hopefully mitigates some concerns about benzodiazepine dependence and misuse. And I think also, again, highlights that urgency to treat once a seizure cluster is recognized and not needing to wait for that prolonged 5-minute seizure mark. And with that, I want to thank you for your time and attention. And if there's time, I take questions.